So I just wanted to say a quick welcome to everyone. It's lovely to see you all. Thanks for joining us. So for those who don't know me, I'm Katrina with TSA's nurse. So I'd like to just warmly welcome our speaker for tonight, who's Dr. Kaushi. Before I hand over to her, I just want to make sure we understand what we're doing tonight with all our tech. So down the bottom, we have speaker or gallery view, and you can come off mute by holding the space bar. And there's also a chat box if you have any questions down the bottom. You can have any questions you have, you can put them in there, and that's a public chat. And I think everyone's pretty over Zoom, like everyone knows exactly what they're doing now. So the other thing I just wanted to let you know, you can put questions in the chat box. We'll give you an opportunity at the end if you have any more questions. And we are recording tonight's presentation so we can pop it on our website because Dr. Kaushi will have lots of valuable insights for us about TSC and the menstrual cycle. Dr. Kaushi is a gynecology fellow with Southeastern Sydney Health District working out of Randwick Hospital. She's going to discuss managing the menstrual cycle in patients with TSC, and she will also touch on a couple of other topics related to women's gynecological health, including fertility, pregnancy planning, and general women's health issues which are relevant to our TSC community. So just please join me in welcoming and thanking Kaushi for joining us. So thanks very much, Kaushi.
Hi, everyone. Thank you, Katrina, for the kind introduction, and thank you both for inviting me to speak today. So as Katrina said, happy to sort of field any questions towards the end of the presentation, but if you have any burning questions, I'm happy to interrupt and sort of answer any questions as we go along as well. So we'll try and keep this as as interactive as possible. All right, so I've been asked to talk to you all about the menstrual management and a little bit of focus on fertility and pregnancy planning. So basically, I've seen a lot of the TSC patients that I've been involved with have largely been from an adolescent gynae perspective, but it would be a very sort of similar management going into adulthood as well. So I guess a lot of it all begins really with puberty. And this is where we see the bulk of our patients initially. So I think it's important to have an appreciation for what happens at puberty, because I think we get a lot of referrals about parents who are very distressed about their child going into puberty as to how that might manifest for them, because a lot of patients either have seizures or they're not verbal and unable to communicate if they're distressed in any pain. So it's important to understand when that process of onset of your periods may occur, and that's to do with the stages of puberty or your pubertal state at that point. So the very first stage of puberty that we often see is the development of breasts, and that's often that very early first sign that we see in young girls, and then that sort of then moves on to development of pubic hair and axillary hair. And then we see an increase in growth. So typically this is the telltale sign that period's about to start soon. So it's when young girls have that peak increase in growth velocity, and typically about 2 years from their peak growth, that is when we tend to have them starting their periods or menses. So a lot of the patients that I see are actually pre-menarche, so before they've started their periods, but they've had all these early signs of puberty. So we sort of talk to parents about having a general plan going into their first period and what steps we can take to try and make it as comfortable a process for them. Now, a little bit about the menstrual cycle that I think is important to understand. Most girls, the average age is sort of 12.5 years, but it's very variable and it can vary from patient to patient. So it can be as early as 9 and it can be as late as 16. So if it hasn't happened by 12, 13, don't get stressed because it can happen much later. And so we only start to sometimes see patients, in the non-TSC group as well, once after 16, that's when we get referrals. Until then, it's very normal to have that wide age range when having the first period. So, or especially if a patient has all those prepubertal signs that we talked about of the breast development, the hair growth, then you know, and they're achieving, if they manage to achieve their peak growth velocity, then you know that the period's going to be impending. So we often reassure parents and say, come back if it's not happened after 16 years of age. Now, the duration of the cycle length, especially when they initially start their periods, that can be pretty irregular to start off with. And that's largely to do with the fact that the axis from the brain communicating down to the ovary is actually quite immature and not well developed. So having an irregular cycle is so common in the adolescent age group. And as girls age and go into early adulthood, we then start to see a maturity in that axis. And so then cycles tend to become more regular. But a lot of parents we see come to us in that early stage because they do get a little bit stressed about the cycle irregularity, or girls can find it a bit distressing because there's random spotting. But it's just something we can definitely help manage that. But it's not uncommon to have that in this age group. So I quite like this picture. It's a very busy slide for sure, but I quite like this sort of pictorial view. So if you look here, I hope you can see my cursor. So this is basically telling you what happens to the lining of the uterus during a menstrual cycles when you get your period. And then the top graph here tells you what's happening to the ovary. So it's all linked by these hormones that sort of regulate this whole process. So the hormones are released by the ovary, and then they basically have an action on the lining of the uterus. So you can see here where it says menses, this is your typical day 1 to 5, and you can see that that lining of the uterus is shedding, and that's when girls get their period. And then once you've sort of surpassed 5 to 7 days, and it can be very variable, you can see that there's slow growth of the lining back again, and then that goes into sort of what you would expect as you get repair of the lining of the uterus, and that's largely governed by this hormone here, progesterone, and then the initial bit, which is to do with this loss of hormone. As you can see, the estrogen levels are low, is to do with basically what corresponds to shedding of the lining. So it gives a nice sort of pictorial view that the hormones fluctuate, they're not a constant, and they fluctuate, and they're responsible for whether the lining gets shed or doesn't get shed. And this is where we form the basis of manipulating a cycle when we need to manage the menstrual cycle for a TSC patient, for example. So the hormones that govern a cycle, as mentioned in the previous slide, you have estrogen, and progesterone. So estrogen, its role is to stimulate the growth from the ovary of follicles. So follicles are little envelopes that contain your future egg. And so they aim to basically promote ovulation. So every month, ideally, you'd be releasing an egg or ovulating. And that's at the level of the ovary. And then at the level of the uterus, you've got that repair of the lining of the uterus, which is what we saw previously. And then you've got progesterone, which is also released by the ovary, but that's released by the ovary after ovulation. And that basically, it further thickens the lining of the uterus because it's now anticipating a possible pregnancy. So this is where we try to manipulate the cycle by controlling the role of the estrogen and the progesterone. So menstrual symptoms can be variable, and they can vary from really painful periods, heavy bleeding, prolonged bleeding. Some patients can get spotting before their period. A lot of patients can get mid-cycle pain, especially with TSC patients, if they've got any history of seizures. Sometimes you can get cyclical seizures, or it can make lower their seizure threshold and make it worse. There can be an association of mood symptoms which can occur prior to the onset of their periods. bloating is quite common, breast tenderness, and acne, to name a few. It's very, very variable. I haven't mentioned it here, but some patients can also get headaches or migraines as well. And if you take a deep enough history, it's often a cyclical nature. And if you get them to write it down, or if you make note of it, sometimes it can be related to pain just from the period as well. Okay. So this non-hormonal management of the cycle, I often start with this whenever I speak to anyone who's looking at manipulating their cycle. So if you think that the main issue in the cycle is largely the pain because they're distressed or they're clinging onto their tummy or they don't seem very comfortable, and you know the volume of bleeding, which is very variable, but the best way to ascertain it is the number of pads or how many tampons one is using or diapers, then that gives you a good idea of the level of volume of bleeding. So mefenamic acid, which is also known as Ponstan as a generic name, is very similar in its action to, say, ibuprofen, for example, but it's very focused on menses. So it helps to reduce pain, and it can actually reduce the volume of bleeding by 40%. Now, obviously, this is not a medication that you'd want someone to be taking daily because it can affect the lining of your stomach. And often you could be on a lot of other medications as well. So usually this is targeted and taken only for those first couple of days when periods ensue. Certainly can be taken on top of any hormonal management, which we'll get to in the subsequent slides, but it's a non-hormonal option if you don't feel strongly about taking anything hormonal initially. And sometimes on my adolescent side of patients, I sometimes find parents are a bit reluctant to start patients on any hormonal management initially, so we can always try a non-hormonal route if needed. Then tranexamic acid. So this is another non-hormonal medication. It really works well to reduce the volume of bleeding in a significant way, and it can be taken orally. And if the bleeding is really bad and you were to present to the emergency department, for example, it can also be given intravenously as well. It's very effective, but we say no more than 5 days. So again, it's something that you would only take at the time of your period and no longer than that, because the other side of it is if you take it for too long, it makes your blood really thick, and therefore you can increase the risk of blood clots. So that's not something you want to do, especially if you're not very mobile and you have other medications that you can be on. So that it's very risky in that sense to be on the tranexamic acid for prolonged use. And again, these two can be taken in combination, but with all the cautions applied in terms of the duration of its use and how it's taken. So moving on to hormonal management. So this is something that you could pretty much consider putting someone on if they don't have any specific contraindications. And I'll look at those special situations with TSC patients as well. So the estrogen progesterone combined pill, and there's a whole variety of them. So you have low dose hormone levels to higher dose to variable strength ones. But in essence, they all work by trying to block ovulation. So therefore, you're blocking the hormone release by the egg. And so you prevent any cysts from forming, you reduce the flow of the period. Remember, the cycles can be quite irregular, so you bring about a regular cycle. And if needed, you can actually run this packet. So if you look at this packet here in this picture, all of these tablets here are called the active pills, the yellow ones, and these white ones here are called the non-active or sugar pills. So sometimes I say to patients, you can actually run a packet. So instead of taking these white pills, you come to the end of this pill and you go into the next packet and start straight on to the other active pill. So you sort of do what we call like a back-to-back packet. And so you can do that for 3 months, for example, where they get no period. And it's great for patients. They're not as distressed in pain. There's no bleeding. And then you can let them have a break and take the sugar pills of the subsequent packet. So there's a bit of flexibility. And especially if you're traveling or you're going overseas, or you're in an area where the last thing you want to do is have your period, this is a perfect opportunity to do that. And in addition to helping control your period and your flow, it also, because it blocks ovulation, it has a dual effect. And so it works as a contraceptive as well. So obviously for some patients, that's not the main target, but there is that additional benefit as well. As with all medications, there are side effects, and I can appreciate, that these are patients that may be on other medications. So we've got to balance it out in essence. And so it won't be a one size fits all. It's obviously going to be a customized, tailor-made management plan for each patient. But some of the side effects that you can expect are mood change, weight gain, headaches sometimes, and even nausea. And it might mean a matter of switching the pill, or it might mean trying one of the other hormonal management options that we'll continue to talk about. The other form is a progesterone-only pill. So this is, again, another form of hormonal management. So it doesn't contain any estrogen. It contains progesterone alone. So this works in a slightly different role. It may block ovulation, it may not block it. So it doesn't prevent that formation of cysts. So you may sometimes have that mid-cycle pain because you've formed a cyst which is ruptured sometimes. And it's just one of those things that can be quite uncomfortable for patients if they're especially that mid-cycle pain. And often it could just settle on its own. But the pill is pretty good at preventing that from happening. And sometimes that's one of the reasons patients can present to ED. But the progesterone-only pill, unfortunately, there's no guarantee that it may do that. So it's one of the downsides of it. But it might be a better option for patients who can't take any estrogen-based medications, if they've got seizures and on anti-epileptic medications, or they've got LAM. Those are all conditions that maybe this might be a better targeted pill in that sense. So the progesterone pill also works well. It reduces your menstrual flow. And again, it has a dual effect in that it's contraceptive. Its side effects are a little bit different to the one with the estrogen-based pill. So you can get irregular spotting on it, and it's one of the commoner side effects. Some patients may be okay with that. Other patients, they might find it quite distressing. So it's something to consider. Breast tenderness, bloating are common as well. Mood change can occur with them, and formation of cysts, which is what we talked about earlier. Now, this is another form of a progesterone-only medication, but instead of being an oral medication, so you don't have the concerns for swallowing something, if taking tablets can be challenging, then you can have a Mirena, which I'm sure many of you have heard of, inserted. Now, this works by acting locally on the uterus, so it has very minimal systemic side effects compared to the oral forms of progesterone or even the estrogen progesterone pill. It may block ovulation, again, partially, but it works really well to reduce menstrual flow. In fact, 20% of patients have no periods at all. And some patients absolutely love it because, parents or carers of those who have TSC and the patient doesn't have any periods, they actually really enjoy having the Mirena because they see a significant decrease in mood symptoms, seizure issues, or any signs of pain or distress. So it works really well. Obviously, it has a validity period, so it needs to be changed every 5 years. And certainly this is something that we would do under an anesthetic. Usually if they're having other anesthetics, we can time it with other procedures. But the one thing with the Mirena that's really important to remember is that it doesn't work overnight. So it takes about 3 to 6 months for it to become fully effective. And again, it works as a contraceptive as well. And it's a really efficient contraceptive because it doesn't rely on you taking anything. It sits there and it's there for 5 years. But the risks, I guess, which I've mentioned, are actually in the first 3 weeks of insertion. And if it's usually inserted pretty well under an anesthetic, then the expulsion risk is very, very minimal. Probably less than 1% will have what we call a sort of a hole in the uterus or a uterine perforation. Again, if it's placed under an anesthetic, it's usually done pretty well. The random spotting is possible, but as I said, that's something that can settle with time, and very minimal systemic side effects. The younger you are when having a Mirena, so often I say with the young girls, I wait 2 years from the onset of their periods because their uterus is very small and it can't entertain having a device in at the time. So I would monitor the length of the uterus before we put one in. But once you go into adulthood, it's less of an issue, but we always try to get an ultrasound if possible before putting a Mirena in, so that we're not, if you have a big fibroid or you have a polyp or something that could impact the Mirena sitting or doing its job properly, then at least we know about that prior to subjecting one to an anesthetic. So I often like to get an ultrasound if possible. And usually an ultrasound will be just done over the tummy to have a good view of the uterus at the time. Okay. So one of the issues sometimes with a lot of those hormonal medications that we talked about is bloating and weight changes. And this medication, Celinda, is actually a newer progesterone-only medication, which actually works really well for patients with any bloating that they experience. And it actually, in terms of mood symptoms, however, it can sometimes be an issue. So as I said, again, this is sort of finding a customized, tailored approach to what works best for the patient in front of you, what the main issues are. So Celinda is really good in terms of working to reduce the blood flow, working to regulate the blood flow, working to reduce any bloating. It can help with acne as well because it contains a anti-androgen component. So androgens are hormones that can contribute to acne. They're like the male testosterone sort of version, but Celinda works well to block all of that. So a lot of patients do like it. But one thing is, if you have pre-existing mood issues, it's one of those things that is not ideal. And then there's Provera, which has been around for years. And that basically, it has no contraceptive effect. So if someone says, look, I just want the flow of the bleeding to stop, and I just want them to have good control, then this is a tablet that you would just take daily to just help with the blood flow and thereby reduce the associated pain and any distress caused by it. It is not a contraceptive, but it works well in this regard. However, it requires taking a daily tablet, and that may be challenging for some patients. So I guess special considerations, and this is where it might be applicable for some of our TSC patients. So venous thromboembolism, so the risk of blood clots, if you have any pre-existing risk factors, you're not very mobile, then you want to probably try and avoid any estrogen-based medication. If you're very headachy or you've got migraines and any associated aura with it, auras is sort of like this sort of premonition or sort of a feeling that you get before you actually have a headache. Any of those symptoms, you want to avoid giving anything estrogen-based. So therefore, in these sort of situations, a progesterone-based tablet or the Mirena would work fine and is absolutely safe. There's no concerns for clots in that situation. And then epilepsy or any seizures, you've got to be cautious about looking at any estrogen-based medication for two reasons. Number one, the estrogen can lower the seizure threshold because it may interact with the metabolism of the drug that you're taking. So for example, lamotrigine. So therefore, you need to be cautious about lowering the seizure threshold and therefore increasing seizure activity. So I think it's one thing to bear in mind when you're taking comprehensive history from these patients. We always ask about medications, and it's always good to go with all the medications and any doctor's details that you've got because there can be drug interactions. So that's really important. And I guess also where it's being used as a contraceptive, certain anti-epileptic drugs can affect the efficacy of an estrogen-based contraceptive. So that's just something to bear in mind as well. Now, difficulty swallowing oral medications is one of the challenges. Some medications can actually be crushed if there are any issues with taking oral medication. I often say check with the pharmacist prior, and I often check with them before we sort of go ahead with that medication. But there is that alternative route of having crushed medication if the oral options suit you better or seem more sort of enticing compared to maybe the Myrene or any other options. So that's something to take into consideration. And then obviously with TSC patients, the risk of LAM can always be there. And I'm sure some patients are being monitored for this as well. The idea with LAM, I think, is concerns that estrogen can drive the growth of LAM. So if you're a patient where there's the worry for LAM and that possibility, then should probably be mindful about taking any estrogen-based medication if there's concerns for stimulating growth. So again, this would be sort of collaborative care that we would have with the specialist who is looking after a TSC patient, and sort of, written communication to say, is this medication appropriate? Are you concerned? And if there is, then we'll just go for an alternative medication. So contraception, which I've mentioned previously, the anti-epileptic drugs can sometimes affect the efficacy of the pill. And so it's really important to make a note of that if you are using it for contraceptive purposes as well, then if you're on other medications, it's really important to assess if there are any drug interactions. So always have a chat to us about those things, because we can look at alternative contraceptive methods as well. Right. So the other hat I wear is fertility. So I do a lot of gynae, but I focus on fertility. So I guess with TSC, most patients have a random mutation usually. And it's sort of like a de novo mutation, and having that family history or inherited sort of gene is quite rare. But when inheritance does occur through the family, it's usually in an autosomal dominant pattern, which means it takes one affected parent to pass it on to a child. So there is sort of that 50% chance of passing it on. And so if you are contemplating pregnancy and you want to avoid passing on the genetic condition, then one option would be to undergo an IVF cycle to basically create embryos, and then you can actually test the embryo for that specific genetic condition before you put the embryo in. So in summary, you'll just wipe out the gene for sort of the next generation to come. Obviously, de novo mutations can be tricky in that sense, and often we have a reproductive genetics counselor and a geneticist that we send our patients to if they want to have a chat about it and talk about the possibility and the chances of them having a child with TSC. So there are certainly ways in the realm of fertility where this can be prevented if there's a concern that this is an inherited pattern rather than a de novo pattern. And just on that note, I know fertility seems very expensive for sure in the terms of IVF, but I actually work in a public clinic at the Royal Hospital for Women here at the Fertility and Research Centre. And so we are happy to see any patient. And it's actually a much cheaper option for patients compared to going private. So for a standard IVF cycle, it would be something in the realms of $1,000. And if you were to have genetic testing of the embryo, you're probably looking at something in the realm of $4,000 to $5,000 as opposed to $15,000 to $20,000 privately. But obviously, public limitations are always there in terms of wait lists and times, but that's always an option, and you can always have a consult with us in the public clinic, and very welcome to see patients from all areas, New South Wales and even outside of New South Wales. So moving on to pregnancy planning. So I guess this is sort of like a general discussion about pregnancy planning for anyone who's contemplating pregnancy. I think this, and probably GPs are the best sort of educators here in terms of having that opportunity to see a patient and make sure everything's sort of ticked off. So I always talk about really employing a healthy lifestyle. So, you know, alcohol, smoking, making sure you optimize all of your health conditions. And that's why seeing a GP is good, making sure you're on medication that's actually safe if you were to fall pregnant. Good exercise, diet, really important. Folic acid is so important. And I guess in Australia, we're very lucky. We have a lot of folate in the diet that we consume. Now, your standard Elevate or Blackmores will only have 400 micrograms of folic acid, which is not ideal in certain groups of patients where the BMI is elevated or they have poor absorption, in which situation I always say take 5 milligrams of folic acid. And really that folic acid is really important in the first trimester of the pregnancy. So I often say to patients, if you can at least, if you're thinking about having a baby, start now. So at least a good 3 months in. Ideally, you just need it 1 month prior to having a baby, or falling pregnant rather. But if you can at least start 3 months before, because we don't know how long it's going to take to conceive, that would be an ideal situation. Now, reproductive carrier screening, it has really blown up. I think it's huge since Scott Morrison made it sort of part of the Medicare availability, since the whole McKenzie mission sort of screening process really took off. So what it is it's the common conditions for reproductive carrier screening. So this is screening. It does not sort of look at the possibility of saying that, you know, this patient's going to have an absolute diagnosis of this. So the screening test basically looks at you or you and your partner for any to see if you're like carriers for any genetic condition that you together can potentially pass on to your child. So in under the Medicare belt, you can be covered for reproductive carrier screening for 3 conditions: cystic fibrosis, spinal muscular atrophy, and Fragile X. But there's a whole array of other conditions that you can be screened for. And usually at the moment, that process is an out-of-pocket cost, and a lot of companies are doing them, and it's actually not a bad idea. So you can start by maybe doing one person doing it, and if that person's found to be a carrier for any genetic condition, then it might be worth the partner doing it. If you're not found to be a carrier, you don't need to test your partner. Or you can have both you and your partner being tested for it. And then if you're found to be carriers of the condition, then you will be referred automatically to see a genetic counselor or a geneticist. And that's when they'll talk to you about that reproductive risk of passing it on to a future child. And that is where we can come into play and help you with that IVF cycle process and trying to create embryos and test those embryos for any genetic condition to try and negate having an affected embryo. So really, really important to do reproductive carrier screening. If you've missed the window for carrier screening, then obviously there's opportunities in the pregnancy to try and test for it. But for any specific condition, if you find out in your pregnancy that there's some strong family history of a particular condition, then yes, you could. And if you're later found to be positive, then that's an opportunity. But it's ideal to try and have this done prior. Really important to be up to date with all your vaccinations. So this is that really important time, making sure your rubella is up to date, making sure your chickenpox, you know, if you've never had it, that you're actually immune to it. Hepatitis B, all of these are classic viruses that you want to try and avoid getting in pregnancy because it can have implications for the bug. Some of those conditions, especially rubella and varicella, really important in the first trimester to avoid, because you can have an affected child. And then this is also a good time to make sure you're up to date with your pap smears or cervical screening tests as well. So in Australia, it's basically from the age of 25 of onset of sexual debut, and it's done as a 5-yearly screen. So really important to make sure if you haven't had one done in the last 5 years, or you've never had one, but you've been sexually active, then it's an opportunity to have that done as well. There is the option of doing self-screening if you don't want it to be done by a clinician. However, it's reasonable, but sometimes when it's done by a clinician, the detection rate is slightly higher for any abnormalities compared to if you were to do a self-screening where you take the swab and swab it yourself. So this is what I say to all patients wanting to do any form of pre-pregnancy planning. And we actually have here at the Royal Hospital for Women, we have a planned clinic. It's a good opportunity to actually, it's run by one of our very esteemed nurses, and they go through all these options with you. And if you're keen to do reproductive carrier screening, they can point you in the direction of the various institutions that carry it out as well. So it's sometimes just to have that chat, it's a good opportunity rather than having to burden yourself and look for all of this on your own. And then once you're pregnant, I think, especially in the context of TSC, it's really important that you're managed in a specialized clinic or in a tertiary hospital, because we'll have the care of obstetric medicine. So these are physicians who specialize in obstetrics or pregnancy. And so they'll be able to talk about how the pregnancy can impact TSC and how TSC can have implications on the pregnancy and the birth. So really, really important to be seeing them very early on in the pregnancy and have that referral made. And then throughout your antenatal care, you'll be seeing in that sort of high-risk clinic, and it will largely probably be a doctor-led clinic with midwifery input as well. And it's really important that sort of you engage in the tertiary clinic from as early as possible. Throughout that process, especially if you're on medications such as anti-epileptic medications, again, this is something because of the hormones and the physiological changes that our body goes through in pregnancy, you can expect fluctuations in the levels of those drugs. So monitoring those levels will be important, and we may need to up titrate the dose depending on the levels as well, and also avoiding any toxicity. Pregnancy is a vulnerable time. You can be predisposed to other conditions in pregnancy as well, such as diabetes, blood pressure issues, preeclampsia, which is a complication from blood pressure. And it's also important to monitor the growth of the baby. So these are all things that are really important for any sort of TSC patient trying to engage with pregnancy services. So again, all of this, you kind of want to do in a one-stop shop so that the notes are transparent, everyone can manage you. And they also are excellent in terms of linking in with your specialists as well, especially to do with the medications that you could be on, especially if you're a LAM patient, for example. We know that estrogen does go up in pregnancy, so trying to sort of monitor the progress of that and whether it's safe for you to embark on pregnancy. All of these are sort of addressed at that time. So really important to have that sort of consultation. And that's pretty much the bulk of my talk. I'm happy to open the floor to any questions that you may have, or you can also email me if you think of anything afterwards as well.
Thanks so much for that, Kaushi. So we've got one question in the chat. Is estrogen contraindicated also due to the effect on the kidneys with AML growth and not just LAM, is the question.
Yeah, that's a good question. So I think if the concern is that the growth of AML is largely related to estrogen, and if often with these sort of cases, I would speak to the specialists themselves and see what their concern is with estrogen. And if they say that they don't think it's an ideal situation, then we'd just put you on a progesterone-based medication only. So it would sort of be that collaborative care that I would have before I sort of launch into starting someone on an estrogen-based medication.
Yeah.
Yeah, I have a question. I'm Olivia Rosewell's mother. How are you all?
Hello. Hi.
And I was just wondering, the Marina, if it stays in longer than 5 years because the hospital has lost the referral, what would happen to that Marina or yourself if it's left in longer than 5 years?
Sure. It's not a problem. You only start worrying that the Mirena is probably not doing its job in terms of the hormone control. I mean, sometimes I have patients where it's extended into the 6th year. So often it's just a situation of trying to get into theatre as soon as possible to try and remove it. But most of the time they come out quite easily. There's no concern for major, embedding or anything. But I had one patient with TSC who had actually had her Mirena in for almost 6.5 to 7 years, and she started getting some green discharge, and that was just the Mirena just being there for too long and needing a change. So yeah, just got her into theatre as soon as we could, and there's been no signs of discharge since the replacement of the Mirena. So there's no major harm, but patients can start to become symptomatic. So yeah.
I think they are on top of it, but it's just that there was just a bit of an issue with the referral, but that's okay. It's not quite 5 years yet, so I can be rest assured if it's a bit longer, it's okay.
Yeah.
And the other thing is, have you seen these TS growths on the ovaries or the uterus or anything like that in your experience?
I haven't seen any in my experience so far. I'm aware of the issues with the lungs, but no, I haven't seen any growths in the ovary or the uterus. But we often, with these patients, do have a basic scan initially. And obviously, if there's any concerns that they've got additional growths elsewhere, then you could look at doing some surveillance. Again, this would be a customized approach because not everyone would have LAM or any of the other complications. So we'd do it based on if they have any concerns for additional growth.
Be an ultrasound of the
yeah, an ultrasound would be a perfectly sort of relatively non-invasive modality to assess that, and you can always compare with prior images as well. And again, I often say if you can, try and go to a dedicated women's imaging place because that's their bread and butter, and they can look at images.
Yeah, okay. And just one other question, sorry to hold everyone up, just with when you have the Mirena changeover, and can they do the pap smear at that time under general anaesthetic as well? Because it's only like another quick little test, isn't it?
Absolutely, yeah. It's a perfect opportunity to try and get all those additional tests, especially if you have blood tests or something that needs to be done, get it all done at the same time, yeah.
It's just due to, I think lack of understanding would be the issue with my daughter. So just get it all done at the pap, get the pap smear and the changeover Mirena.
Yeah, you can do it at the same time. And again, funnily enough, the pap smear and the Mirenas only need to be done 5 yearly. So
I know, it's perfect, isn't it?
Opportunity, yeah.
Yeah. All right, great. Well, we'll advocate for that. Thank you.
No worries.
Michelle. I was just going to quickly ask, is there a particular time in the cycle that is higher risk for epilepsy, migraines, etc.? Like, is that more like a luteal phase or?
Yeah, good question. So I often, it's that mid-cycle, just after that ovulation, that's when patients tend to get that increased risk of migraine or seizure risk as well. So the goal there is where the pill comes into place. If you can block ovulation, then you're working well towards trying to reduce the increased risk of seizures and also the risk of migraines as well. But migraines depends, as I said, if they've got an aura with it or not, because estrogen-based pills can sometimes be an issue there.
Hi, are there any long-term effects of having a Mirena from a younger age? Like, so say you've changed it 4 or 5 times in the future. Yeah.
No, I mean, I think we tend to say a girl goes through her first period at the age of 12, for example. So typically, if you're looking at putting the Mirena in around 14, 15, or even a bit older, it's not a problem. to having repeated Mirenas. Absolutely fine. Yeah.
Great, thank you.
Something on the chat, I'm not sure. Oh yeah, okay. Sorry, just saw, is there any from Mary? Is there any contraindication with being on everolimus and having a Mirena? Everolimus being similar to tacrolimus, is that right?
So yeah, it's an mTOR inhibitor. So
Okay.
either sirolimus or everolimus, just depending.
Okay, yeah, that's fine. Yeah, no, there's no contraindication with that. Yeah, it's fine.
And this is probably a very difficult question to answer, but have you got any sort of anecdotal evidence about behavioural, because especially non-verbal kids, it's difficult. So behavioural issues just around before a period, we find that's happening. So
yeah, no, it's a really good question. In fact, I had a patient just on Tuesday going where the mom called because she hasn't yet started her period, but she's got all the telltale signs of puberty, and her mood's just been going up and down, and she's on the brink of starting her period. So it's very common, but I think it's just hard to manipulate the cycle until they actually start their period. So just a lot of reassurance that we can try and get in. So we had lots of strategies in place about what we would introduce as soon as the period starts. She actually wanted a Mirena straight away, and then we did a scan of the uterus. She's only she's a very young girl. She's not even quite 12. She's actually 10 and a half. But it was very, very small and very prepubertal. So I've had to say, look, we're going to have to hold off on the Mirena, allowing that uterus that chance to grow. But there's a lot of oral medications that we can give and can be crushed in some situations if needed. So just a lot of reassurance. But what I do with these patients is I try and keep them in close loop rather than saying, come back in a year, maybe come back in a couple of months, but reach out to us sooner if needed, because I think it's a huge time of angst. I mean, puberty is a big deal in general, but then on top of that, when you've got other associated issues with behavioral things, they can be quite tricky. So unfortunately, can't manipulate the cycle quite yet, but it's just having those strategies in place going into an upcoming cycle.
Thank you.
Any other questions or any comments or anything?
Sorry, I might have one more.
Of course, yeah,
sorry.
of course.
It's great to have you so we can ask these questions.
Yeah,
so if someone's on a Mirena and they don't get their period, how do you monitor a cycle though? So is it just you can't? Is that the
yeah, you can't. I mean,
yeah, right.
it depends. You're trying to achieve symptom control with the Mirena. So what you're doing there is basically the cycle in essence is what you're trying to control. So you can't, it's not like they shouldn't be having a regular period.
Yeah.
As I said, after the Mirena's kicked in 3 to 6 months into it, most patients have either no periods in 20% of cases or just maybe a bit of spotting, like nuisance spotting, but there's no way to regulate monitor that per se. But you might, as I said, the Mirena doesn't block ovulation all the time. It partially does. So you might find a behavioral change somewhere like mid part of the month for each patient. And that might be a sign that they're ovulating, and it might mean a matter of supporting them with additional medication around that time frame as well. So yeah.
That makes sense. Thank you.
Is there something in the chat? Any tips for premenstrual tension? Yeah. No, that's a fair question. So again, classically, we see that sort of going into sort of ovulation. So again, trying to block ovulation is what's going to help in that sense. So it'll have to be hormonally managed medication. So again, if you can take an estrogen-based pill, that's fine. The progesterone-only pill, which we talked about, which is Celinda, that works really well for premenstrual tension and any associated mood with that. But those options would be perfect to managing that overall.
I was going to say a big thank you to Kaushi, because we don't often get people talking about this, and it's a big issue for our patients. And so we're just really grateful for you giving your time tonight and coming along and just supporting the TSC community, because I think a lot of people in this community are trying to navigate this one for their loved ones and themselves on their own. So we really appreciate your time and coming in and giving us all your expertise. Thank you very much.
No worries. Thank you very much for the opportunity. And as I said, feel free to email me and I'm very happy to sort of reach out and support you all with any advice.